Chapter 12, Central Nervous System Depressants and Muscle Relaxants. With CNS depressants, you have sedatives and hypnotics. Sedatives are drugs that have an inhibitory effect on the CNS to the degree that they reduce nervousness, excitability, and irritability without causing sleep. Hypnotics cause sleep. A sedative can become a hypnotic if it's given in large enough doses. Sedative/hypnotics are dose dependent. So at low doses, they will calm the CNS without inducing sleep. And at high doses, they will calm the CNS to the point of causing sleep. Examples are barbiturates, benzodiazepine, and there are some others. So for benzos, they have favorable drug effect profiles, efficacy, and safety. They're classified as either sedative/hypnotic or anxiolytic, which is a medication that relieves anxiety. Their use is short-term. That's very important. It's short-term use we would use these for sedation, sleep induction, skeletal muscle relaxation, anxiety relief, and treatment of alcohol withdrawal. Benzo's mechanism of action is to depress CNS activity, affect the hypothalamic, thalamic, and limbic systems of the brain. It does move to benzodiazepine receptors, do not suppress REM sleep as much as barbiturates do, and it does not increase metabolism of other drugs. You have long-acting benzos, intermediate-acting benzos, and short-acting. Some examples of long-acting include clonazepam or Klonopin, diazepam or Valium, and flurazepam or Dalmane. Intermediate-acting include Xanax or alprazolam, lorazepam or Ativan, and temazepam or Restoril. Short-acting include Versed or midazolam or triazolam. For adverse effects, things that we need to be aware of. So mild and infrequent adverse effects include headache, drowsiness, dizziness, cognitive impairment, vertigo. What is vertigo? Everybody should know that's dizziness, right? Lethargy, quote-unquote hangover effect or daytime sleepiness. And there are also quite a few age-related considerations in conjunction with benzos. Toxicity and overdose includes somnolence, confusion, coma, diminished reflexes, do not cause hypotension and respiratory depression unless they're taken with other CNS depressants. Treatment is symptomatic and supportive. Flumazenil is an antidote. We have non-benzodiazepine hypnotics. They share many of the same characteristics as benzos, and we usually use these to treat insomnia. Lunesta is a perfect example of one of these non-benzodiazepines. It was the first hypnotic to be FDA approved for long-term use. It's designed to provide a full 8 hours of sleep. It's considered a short to intermediate acting agent. Patients should allot 8 hours of sleep time and should avoid taking hypnotics when they must awaken in less than 6 to 8 hours. There's a link on this slide for a YouTube video. Then we have Ramelteon or Rosarum. This is structurally similar to the hormone melatonin. It works as an agonist at melatonin receptors in the CNS. Technically, it is not a CNS depressant. It's used as a hypnotic. It's not classified as a controlled substance. It's indicated for patients who have difficulty with sleep onset rather than sleep maintenance, So if a person has a hard time falling asleep, Rosarum is something that we would try. We always need to ask people with sleep issues, do they have a problem falling asleep or do they have a problem staying asleep? Zaloplan or Sonata is a short-acting non-benzodiazepine hypnotic. It has a unique advantage. It stems from its very short half-life. Patients whose sleep difficulties include early awakenings can take a dose in the middle of the night as long as it's at least 4 hours before they must arise. Zolpidem or Ambien. I'm sure that you all have heard of Zolpidem or Ambien. This one is very popular. It is a short-acting non-benzodiazepine hypnotic. It has a lower incidence of daytime sleepiness compared with benzodiazepine hypnotics. Ambien CR is a longer-acting form of the drug with 2 separate drug reservoirs. So Zolpidem, though, one thing that you do need to know and you need to pay attention to, it is considered a high-risk medication for individuals over the age of 65. Herbal products, kava. It's used to relieve anxiety, stress, and restlessness and to promote sleep. It may cause temporary yellow skin discoloration extended and continued intake. It may cause visual disturbances. It does have the potential to have an interaction if the person drinks alcohol or takes barbiturates, and any other psychoactive drugs. It's contraindicated if a patient has liver disease, is an alcoholic, or there's a few other conditions. The patient should not operate heavy machinery during use. Then we have valerian, also an herbal. It's used to relieve anxiety, restlessness, and sleep disorders. It may cause CNS depression, hepatotoxicity, nausea, vomiting, anorexia, restlessness, insomnia. Many interactions, including with the CNS depressants, MAOIs, seizure medications, warfarin, and alcohol. It is contraindicated in cardiac and liver disease. The patient should not, once again, operate heavy machinery during its use. Now let's talk about barbiturates, which are sedative/hypnotics. They are habit forming. They have a low therapeutic index. Only a handful commonly used today due in part to the safety and efficacy of benzodiazepines. The dosage range is within which a drug is effective, but above which it is rapidly toxic. So adverse effects include this for the CNS system. They can include drowsiness, lethargy, vertigo, mental depression, and many others. For respiratory adverse effects, you could see respiratory depression, apnea, bronchospasms, and cough. Once again, any medical terms that you do not know, please write down on an index card, look up the definition, and start testing yourself. We also have the body system, nausea, vomiting, diarrhea, others. So GI wise, you could see constipation, you could see diarrhea, granulocytosis, hypotension, and Stevens-Johnson syndrome. Look up Stevens-Johnson syndrome. You should be aware of what that is. And agranulocytosis. Jiminy Christmas. Sorry for the pronunciation problem. I'm tired. Okay, let's keep going. Continued adverse effects for barbiturates include reduced REM sleep resulting in agitation, inability to deal with normal stress. When do we restore our energy? What stage of sleep? That's a question that you should think about and come to an answer with. That will make more sense if you are able to do so. Toxicity and overdose is also an adverse effect we need to watch for. It does lead to respiratory depression, or it can, if we are experiencing an adverse effect, can lead to respiratory depression and subsequent respiratory arrest. Overdose produces CNS depression. So sleep to coma and death. Move from sleep to coma to death. It can be therapeutic, anesthesia induction, uncontrollable seizures, so phenobarbital coma is also a possibility. And let's talk more about phenobarbital. It is a prototypical barbiturate. It is a long-acting drug. We use it for prevention of generalized tonic-clonic seizures and fever-induced convulsions, as well as treatment of hyperbilirubinemia in neonates. It's rarely used today as a sedative and is no longer recommended to be used as a hypnotic drug. Over-the-counter hypnotics, non-prescription sleeping aids often contain antihistamines, which have CNS depressant effect. You have Unisom, Sominex, extra strength Tylenol PM. Those are all probably medications that you've heard of, and either you have used them or maybe a family member. As with other CNS depressants, concurrent use of alcohol can cause respiratory depression or arrest. Now let's talk about muscle relaxants. They act to relieve pain associated with skeletal muscle spasms. A majority are central acting, so the CNS is the site of action. They are similar in structure and action to other CNS depressants. They are direct acting, so they act directly on skeletal muscle, and they closely resemble GABA. Relief of painful musculoskeletal conditions such as muscle spasms or management of spasticity of severe chronic disorders, multiple sclerosis, cerebral palsy. Those are two major conditions that we will use muscle relaxants for. Adverse effects of muscle relaxants. The extension of effects on the CNS and skeletal muscles. So you will see maybe euphoria, lightheadedness, dizziness, drowsiness, fatigue, muscle weakness, and others. Common muscle relaxants. You will see here baclofen, very common. Cyclobenzaprine or Flexeril is another name for that, also very common. Tizanidine, very common. Methocarbamol, all of these are fairly common here on the list. You should be aware of them.